right, welcome everybody. Welcome to the Medicaid Advisory Committee. I'm Crystal McMurtry. This is a small group to this public forum. I did want to ask everyone here before I forget, is it better if we include the invites to your personal email? Keep in mind that that email could be part of a FOIA request. And I'll send out an email too to do that. So,
yes, yeah, it would technically just be that email. If there were questions, they could, make us look at everything else, but they're going to ask specifically for your emails related to your Medicaid Advisory Council work. So I would recommend you not do business using your personal email, but if you want us to send an invite to it, you should be fine.
I know it's hard to remember to check both. So today we are going to go over the passes. Like I know we said we would do that last meeting. This meeting would be in that. And then Nell is going to speak on the Our Home waiver that just finished public comment. And then Reagan is going to talk to us about the juvenile justice reentry. And then we're going to meet one of the new MCVC members, and they're going to bring to you some of the information that they would like to bring up. And with that, I will pass it off to Tabitha to go over. And you guys should have a sheet in your folder talking about the act that Tabitha is going to go over. Yes, ma'am. I will get you.
Hi, I don't know if it's morning, afternoon, good afternoon. I'm Tabitha McNulty. I'm a Deputy Director in the Office of Substance Abuse and Mental Health, and I get to work with our PASS program. And so today, we're going to talk about one of the acts that was passed in the 2025 session. It was Act 962. And what that piece of legislation does is it requires the PASSes to put on their website some information that the goal behind the legislation is to improve transparency and to give Medicaid beneficiaries the tools to compare between the four. And so the four passes are required to put some information on their websites and do a quality rating system that they do all of this on their own. And some of the information that has to be included in these quality measures on their websites are timeliness of service delivery for waiver recipients, care coordinator caseload ratios, member satisfaction, but it's a lot of different member satisfaction. And an important thing to note about this is all of this information and data that they'll be posting is information that they already gather. So like it's no new information, but it's already data that they're already gathering. They'll just be posting it on their website. Follow-up care rates, post-emergency department visits, well care visit rates for members aged 3 to 21, timeliness and frequency of care coordinator contact, and incidents of complaints or grievances. And so that's the information, and the PASSes have been working internally to make sure that their systems and everything, really their websites, to have that ready to post, and then they have to upload it annually. And then what the state is required to do in relation with Act 962 is that the state has to post a link to these quality ratings that the PASSes are doing of themselves to for our website. It will link members to their website to that quality rating. The other piece that was also in Act 962, it relates to member provider directories, and it requires that the PASSes make available in real time their provider directories to members, and then if there's going to be a change in a provider, if someone's going out of network, that the provider directory has to be updated within 10 days. And so, in short, that is 962. And so if there's any questions on that act, I'm happy to take any. Yeah. Oh, yeah.
Oh, sorry. Thank you. When it's going to be finalized and posted?
I need, that's on me. I need to follow up with the PASSes to get the links. right now, DHS, we're internally working on updating our PASS website so that we have different tabs, like a member tab, a provider tab, a PASS tab. And so I haven't been real aggressive with them about sending that link because we haven't finished our work and made the landing page where that information is going to go. So it really should be any day for them to be posting it on theirs, not necessarily for us to have the link. But yes, I'll follow up and check for sure.
Thank you.
Mhm.
Anyone else?
Okay, thanks.
Okay. Nell Smith will go over our home waiver.
Hello, I am Nell Smith. I am the Deputy Director for the Division of Medical Services, so I report to Elizabeth back there, who I think you all have. This is, I think, my first time addressing this group, and I'm very excited to be here. You may not want me back after this. Okay, so our home. So first, just to level set, what is our home? Our home is Arkansas's Medicaid expansion program under the Federal Affordable Care Act. So this is the Federal Affordable Care Act was back in 2010. It's sometimes referred to as Obamacare, but under that act, states were given the ability to expand their Medicaid program to adults who are below 138% of the federal poverty level. So our home program serves adults between 19 and 64 years old with household income below 138% of FPL. And we currently have about 220,000 people in the Our Home program. So it's a very big program within Medicaid. So in 2025, expenditures totaled about $1.8 billion. So it's a very expensive program serving a lot of people. Fortunately, the federal government pays 90% of that cost, and Arkansas pays 10%, and that is a better match rate for Arkansas than other Medicaid programs. Other Medicaid programs are somewhere around 70% match. So our home, our Medicaid expansion program is we've established it through a Section 1115 Medicaid waiver. So a waiver allows a state to run a program a little bit differently than what is written in federal law. And our 1115 waiver allows us to spend Medicaid dollars to buy private health insurance for our clients. So in our home, we have 6 qualified health plans, 2 providers. So we have Blue Cross and Centene are our 2 carriers, and then we have within them, they each have 3 QHPs, qualified health plans. Our members just have a Blue Cross card. They take their Blue Cross card in or their Ambetter card in, and the provider may not even know that they're on Medicaid. So the waiver also allows us to run another program called our Maternal Life 360 Home Program. And that is a program within the main construct of the program. So the main part of the program is just providing private health insurance to our beneficiaries. But within that, we have gotten permission from CMS to run this program called Maternal Life 360 Home, which allows us to contract with hospitals who then work with home visiting providers to provide home visiting services to women with high-risk pregnancies. So it's sort of a little program within the much bigger program. But the waiver covers both of them and allows us to spend money both ways. So the waiver renewal. CMS approves waivers to last only a set number of years, usually 3 or 5. Our Home program started in 2022 and it expires at the end of 2026, and we are asking to be approved for another 5-year waiver. And state laws, the state legislature gave us permission to pursue authorization for an Our Home extension. So what have we asked for in this waiver? What are we proposing? The big thing, we are proposing to continue our home as it has been run. So we want to continue buying private health insurance for our Medicaid beneficiaries. And second, we've said we want to continue the maternal Life 360 home program and keep spending those dollars in that way. Yes.
Can you remind me, is this on? Maybe? Hello? Maybe. It's on, I guess. Can you remind me about the other two, maybe, I guess now former homes, like the Success, and then what was the other? I can't remember the name of the
So we had Success Life 360 home and Rural.
Rural, yes.
Life 360 home. There was for Rural, I think it was the IT component. The hospitals, we had one hospital apply to be a Rural Life 360 home. And there was some dollar portion of the money, I think it was maybe IT funding. Was it IT funding? Oh, okay, yeah, that's right. So we wanted to, as part of that, a hospital that chose to be a Rural Life 360 home program would be also running an acute care unit. And we had a lot of funding for that ACU operation in with that program. CMS said that we can't spend these dollars on ACU. We had to do that a different way, and so it became less attractive to the hospital. So that was Rural. Success Life 360 home was for a narrow. It was for young adults who needed some extra supports. Young adults who were foster care, previously incarcerated, veterans. So we had a group, but we had narrowed the age range. It was like 19 to 24, 19 to 27, depending on what category you were in. So it was so narrow that it was going to be too hard to run it and get people enrolled. So that one never took off. So we at this point are not, we're not asking to remove it from the authority to do it, but we're not planning to implement. And I think for prosperity, we had a waiver amendment where we'd ask to expand the age ranges, and that never went anywhere with CMS. So that's that. That's a little trip down memory lane. Haven't thought about that in a while. Okay, so what we are planning to do in the our home waiver renewal is we want to expand the types of providers that can be maternal Life 360 home providers. This one has been a pretty popular program. We've got 5 hospitals that are currently participating, but we from the start had PCMA, patient-centered medical home providers, PCPs that wanted to be a Life 360 home provider. We had federally qualified health centers that wanted to be a provider. So the legislature authorized us to open that up to other types of providers beyond just hospitals. And so we are proposing to do that in our waiver, hoping that we can serve more people across the state. Okay. So the next 3 things, next 3 proposal changes are kind of boring, but they're about providing financial stability to the program, and they're sort of technical. But the first thing is pharmacy rebates. Health plans currently, private health plans, all of our private health plans receive rebates from drug companies for doing things that the drug companies want them to do, financial incentives, that sort of thing. So right now, the health plans that are our home health plans receive those rebates and take them back into their own profits and business. We are now asking that going forward, they give that money to us, give it back to DHS, not keep it within the health plan. So that's one thing that we're doing for financial stability. The next thing is medical loss ratio. all of you, if you're in a health plan, you are paying a premium every month, and at the end of the year, if your health plan hasn't spent 80% of your premium dollars on your health care, or on health care in general, not just people individually, then they have to pay the beneficiaries back. So right now that threshold is set at 80%. And we've said for our plans, we want you to increase it to 85%, so that if they're not spending at least 85% on medical claims, they give us money back. Cost share reduction payments. So this is maybe even more complicated than the first two, but health plans that are sold on the marketplace, we're purchasing private health insurance. We're paying, I would say we have a family of 220,000 people, and we're buying 220,000 individual plans on the marketplace. Those plans have higher deductibles and copays than what Medicaid clients can pay. So, for example, if we buy a health plan, and it normally, if you bought it on the marketplace, had a $50 copay, our Medicaid clients don't pay that. We pay that. We pay the difference between the $50 and the amount that we can charge, the $4.70. So that $45.30 is then it's cost share reduction payments. It's a way that we just put in for copays that are too high for our clients. So this cost share isn't taxed the same way that premium is taxed. So what is happening is we are treating that cost share reduction payment as premium to generate the tax. So it's a way of considering it taxable in a way that it wasn't before. That generates a 2% tax revenue that then comes back to support the program.
So I'm assuming that 2% would hit the plan, or would it hit
Hits the plan.
not the consumer, right?
It's the plan.
You can't change the amount that the consumer pays, so it hit the plan operator.
That's right.
Okay, just making sure. Thank you.
Yep. Okay, that's it for the boring expenditure stuff. As I used to say, like a long time ago, the money stuff. So work requirements. You may know that the federal government passed the One Big Beautiful Bill Act, which addresses our home in two ways. One, it creates new work requirements that we have to implement. And then the other is it changes eligibility determinations. Instead of once a year, it's going to be twice a year. Those are things we have to do. We don't need a waiver to do them. We have to do them. So what we're saying is we're planning to implement through the Our Home program. That didn't need to be included in our waiver, but we wanted to do two things differently. We want to introduce success coaching, which would create individuals who would work with our home clients to help them if they need help finding work, or help finding training, or help finding childcare. It's assistance to help them comply with the work requirements. So that is one thing that we want to do. The other thing is an outbound call center. Instead of just having people call in and giving us their information, we want to do some proactive outreach. We know you need to comply. According to our records, we see that you need to comply with the work requirements. We're going to reach out to you to find out, is there something we're missing in our information? Can we make sure that you're actually, if you're complying or you're exempt, that we are aware of that and you don't just fall through the cracks. Okay, timeline. We had to put out our waiver proposal for a 30-day state level public comment period. We also held 2 public hearings. The comment period ended January 12th. We are hoping to submit our proposal to CMS by the end of January. They will then have a 30-day federal public comment period. And then we cross our fingers and hope they get back to us really soon. They don't have a timeline for when they have to give us a decision, but there is an implicit deadline, actually an effective deadline, because our waiver expires at the end of 26. So they have to tell us something before our waiver expires. So somewhere between when we submit and December 31st, 2026, we need a response of some sort. So we're hoping it's earlier, but we never know. And these are the folks that you can contact. Elizabeth and I, and then Jen Dedman runs the day-to-day Our Home operations, and Nancy Watson runs our Life 360 Home program. And I'm happy to take any questions. Anna? Yes.
I've got one.
Okay.
Thank you so much for your presentation. It's wonderful. My question is thinking about the Life 360 homes, adding the primary care component. Curious about, will the primary care providers be providing some prenatal care if there is not one of the 5 hospitals in their catchment area? And then a couple questions about, will they be using universal screening to try to identify early mental health / substance misuse issues? And then what type of on-site interventions will they have access to in that primary care system?
So the first question about PCP. So this program is not providing medical services. All those medical services that the person would have already had being paid for through the Our Home program is going to happen the same way. So it's just home visiting. That's the added piece. But the PCPs and OBGYNs can refer people, and we want them to refer people to the program. So we've said to the hospitals that we're contracting, work with your providers to identify people who could use these services, and then we want you to refer them to the program. So then the home visitor, once the client is enrolled, the home visitor goes out to the house and is screening for all HRSN, SDOH needs, including substance abuse. So those are all questions that get asked on the front end, and they work with the woman for whatever need there might be. Might be housing, it might be, lactation consulting, it might be, there's a lot of different kinds of needs that a woman may have. And the idea is that the home visitor will help with those that they can help with in the home, but also connect them to the resources in the community. Yeah. So it's been a rocky start, just because it's new and there's lots of things to untangle. But I think we're finding some really incredible stories, and I think it can really be a game changer for the people that are participating. So we hope it grows and flourishes.
One other thought as you're talking about that. Will they be identifying women who are in need of services by self-report, or how will the
reporting can be done anyway. So when we started talking about it, one of the things that was very important to me was that we connect. We say to the hospital that we're contracting with, we want you to know the services in your community, both so that you can refer out to that service, say it's a food bank, but also if someone comes into a food bank and she's pregnant, or a church or a homeless shelter, that they connect back into the Life 360 Home program, and so that it's a two-way street. The woman does have to be enrolled. She has to have a high-risk diagnosis code, high-risk pregnancy diagnosis code. So it would, if let's say she's at a food bank and they refer her in, she's got to get diagnosed with a high-risk diagnosis code before she can officially enroll in the program. But we're hoping that it's sort of a two-way street, that we're connecting out and we're connecting in. So that's the idea.
Since we're here, so medically frail. So how are individuals that are 19 to 64 when they apply for coverage? My understanding is they could go into our home, pregnancy the main categories, our home, pregnancy Medicaid, a PASS, or the medically frail fee-for-service program. Is that correct in general? I mean, I know there are others out there like the parent, caretaker, relative, and other smaller groups, but are those the kind of big four, depending on a person's life situation?
Well, yeah, parent, caretaker, relative is a pretty big one too.
Okay. So I guess those
You're
five.
not just talking about exclusively pregnant women.
No, just any adult. And so I guess my question was, is anything changing in this waiver update with the process by which people would go into either medically frail, fee-for-service, or a PASS? Or is that staying the same?
No, we're trying to we're trying to make sure that we don't disrupt the existing processes that we have for people moving into our home, medically frail, all of that. And we're going to hear more about work requirements in April. So there's a weird thing for Arkansas in terms of medically frail. We may or may not get into it, but we're trying to keep everything that we've currently got and the pathway into the program as it is. I mean, without, and then put community engagement requirements, work requirements on top.
And Reagan Cooks will go over juvenile justice reentry.
Good afternoon, everyone. It's also my inaugural address to this group. So my name is Reagan Cook. I am the Social Services Administrator. That's my new title. I report directly to Nell in DMS. So I am actually assisting with the implementation of what's commonly called the juvenile reentry. So here's some background information from CMS, if I can get my technology, yay. So as we're all aware, numerous studies show that incarcerated juveniles experience a high rate of physical and behavioral health conditions. About 90% of them also have some degree of trauma. And roughly 2/3 of the youth in the correctional system report at least one substance-related illness as well. And so what we're trying to do here is improve healthcare transitions for the incarcerated youth. Many of the youth are otherwise eligible for some sort of Medicaid service, with the exception of course, that incarceration. And so access to services may be provided these youths with a bit more stability in their environments. Technology. Yeah. It doesn't like me. There we go. Oh, now it went back too many. There we go. Make sure. There we go. So Congress has shown increasing interest in the healthcare transition for justice that are involved as they reenter the community, as we get the name juvenile reentry. They have amended Section 1902 of the Social Security Act, which prohibits states from terminating the Medicaid eligibility for these eligible juveniles. So previously, they were not eligible for Medicaid once they entered a carceral facility. I'm getting all the technology wrong. There we go. So Medicaid defines an inmate of a public institution as a person living in a public institution, and it defines an institution as the institution that is the responsibility of a governmental unit over which a governmental unit exercises administrative control. Or in other words, you're not there by your own free will. A correctional institution is also considered a public institution. CMS considers any individual of any age to be an inmate if that individual is in custody and held involuntarily through the operation of law enforcement. And those same definitions apply to our CHIP population. And as I stated, Medicaid, if you are an inmate of a public institution, Medicaid considers you ineligible. Federal funds may not be used to pay for services while you are incarcerated. And the CHIP eligibility exclusion, unlike Medicaid, incarceration status is a factor. If you are incarcerated, you are not counted among the definition of targeted low-income child. So it is a factor for CHIP eligibility. Section 5121 of the 2023 Consolidated Appropriations Act is specifically targeted to address this problem. So it's mandatory. It took effect January 1st of 2025, and Arkansas implementation is scheduled to begin April 1st of 2026. I hope that's not forecasting. For purposes of Section 5121, an eligible juvenile means anyone who's under the age of 21 and between the ages of 18 and 26 for the foster care group. For CHIP, CHIP doesn't determine or define eligible juveniles, so it's under 19. And any children within 30 days of their release from incarceration are no longer considered to be the subject of the eligibility exclusion. So within 30 days of their release date from incarceration, they are no longer considered to be excluded from eligibility. So the requirements under 5121 are for Medicaid and CHIP that in 30 days prior to your release from an incarceration facility, that screening and diagnostic services that would be available to you under EPSDT would be provided to those juveniles. Targeted case management services for Medicaid and CHIP members in the 30 days prior to release and the 30 days following release for those members who are eligible. Section 5121 also aligns the CHIP rules to Medicaid rules, so they are the same for this particular section. Currently, the states may rely on carceral and community-based healthcare providers to furnish the services that are being provided during the pre-release services. So if we have providers that are currently in our carceral facilities that are providing these services, we can rely on them to continue to provide these services during this 30-day period prior to release. And then we're going to target community-based providers to provide the services after release for those 30 days. So for Arkansas, we're looking at qualified providers for both the carceral piece and the targeted case management piece. Providers must be enrolled in the Arkansas Medicaid program. They must have full access to all the pertinent records concerning the incarcerated youth's needs. The provider must be able to establish referral systems and demonstrate linkages and referral ability with community resources. So it's important that the carceral providers can also speak to the community providers so that there's this warm handoff of communication of what's needed while they're in the facility and how do we continue those services once they are released from the facility. The provider must ensure quality services in accordance with state and federal requirements. Of course, we want quality services for our members. They must have the financial management capacity. The providers must also have the capacity to document and maintain individual case records and the ability to meet all state and federal laws governing participation of providers in the state Medicaid program. And they also must have the ability to meet all of the documentation, billing, and audit requirements. We would expect a provider to be able to provide our members comprehensive assessments and periodic reassessments of individual needs, a development of a specific care plan based on the information collected through these assessments, referrals and related activities, any referrals that are necessary for appropriate care in their region, make sure that they have transportation, make sure that their appointments are set and following up with those, and of course, any monitoring and follow-up activities. So the way this works in practice is while the member is in the facility will submit an application to the Division of County Operations to get that person enrolled so that we can start their Medicaid eligibility while they're in that 30-day span before they're released. So we're going to move their eligibility from what we call suspended to active in those 30 days so that we can start providing those services. They're going to submit the application. DCO will go through, and if they're approved, they're going to send it directly to this email address. The facility will start providing services through one of our carceral providers at that point. And these are some resources from CMS regarding this particular section in this act. Any questions? And I did not put my contact information. It wasn't intentional, but I did not put my contact information, but I'm happy to provide it should anyone want it. Yes.
Hi, thank you so much. I guess a couple questions. So, I mean, I really loved what you said. I have it numbered on slide 25 in my packet, but it was back a few where you were talking about coordination and collaboration between community providers and the carceral facility.
Yes.
Have you? So, if you all are looking, is it my understanding you're looking for someone to do this right now?
We are looking for
Okay.
providers to start signing up to do this. We are looking at like your well paths, your rites of passage, carceral providers that are already in this space that also have the ability to provide the community care as well.
That was part of the reason I asked, because I wondered if you were looking for folks who tend to do this for adults, but I wondered also if you have run frequencies on, I know that we do this in schools when we're looking at school-based healthcare, but you can run the list of primary care providers for the patients who are in a school-based setting. Can you do that also for youth in these facilities so that you could potentially even recruit the providers who are providing care in the community to come do this as a separate potential line of business for those kids to help ensure that continuity?
We can do that. We
Okay.
can certainly see what PCPs or what providers are in that area, but since they're in a suspended status, I'm not sure that they're going to have a PCP that's assigned to them.
Right, but they would have before. I
Correct.
guess before they went into the facility, like who those kids were cared for by in that setting. And then my second question, kind of related to this, and Elizabeth looks like she might be about to jump in, but
Yes.
I know one of the challenges we have in adolescent care in Arkansas right now is making sure adolescents have all their well visits and all their immunizations and the pieces of care that sometimes if you aren't sick, you don't remember to go in when you're an adolescent for your checkups and such. And I wondered if that could be something that we as a state decide that is important for a child or a youth who's incarcerated to happen before or immediately after their release, kind of like we do when a kid goes into foster care and when they go through the PACE clinics. I believe that this is a particularly vulnerable moment for that child, and let's make sure that everything's going well with their health while we're at it.
You can take it.
Okay. So Section 5121, which is the one is the mandatory section of this, does limit what we can provide. So it does include the EPSDT services, which is a lot of the stuff you just named, the screenings, the vaccinations, all of that is part of it. So they will be doing all of that, and part of what they have to do for the targeted case management is have a plan in place for when that person is released to get them into the services that they need. That said, though, the ability to provide full range services while they're incarcerated is still very limited. It's limited to what's in 5121. So it is going to be those targeted case management and EPSDT services while they're in that 30 days. Now, once they're released, they'll either go into our post 30 days targeted case management that Reagan is talking about, or if they are already, and we think the majority of the kids are already going into a PASS, they'll get targeted case management through PASS. So. And then going back to the recruiting of providers, we are focused right now on recruiting the providers that are already working with our DYS and carceral facilities because they already understand that world, how it works, what to do, and the community resources available. And so that's kind of our focus right now. And then I think this tells you kind of what we'll be looking at as we start to move forward to make sure that we have network adequacy to meet the needs of the entire population. And then the only other thing I was going to add is I just want to touch on the dates real fast. It looks weird that it says January 125 and then we're not implementing for like a year and 4 months. But we're really ahead of all the other states. This was one of those CMS mandates where they really didn't give us enough time to do anything, and they issued the guidance like 6 months before we actually had to put it in place. So it was a little bit of a scramble. So actually we received a grant through DCO to help build out some of the work for this. And so we meet with them, every 2 weeks? A lot.
At least biweekly.
Yeah, a lot. And they're really impressed with where we are as a state and the partnership that we have with our sister division, DYS, and how we are doing this. So it looks like we're kind of behind, but we're really not. And I just kind of wanted to make that point.
Yeah. Those dates are challenging. Yes.
I just had 3 questions. I think this is great because I'm I'll always be, I guess, an adopted parent, but worked in foster care. I'm wondering what the numbers are, one, that's coming out. Number 2, in the assessment piece, just thinking from the provider hat as a waiver provider, if you do with that comprehensive assessment, are we going to be able to link them to get started on, like, if they need waiver services? Is there some IDD there? I don't know what type of clinical profile you're looking at for these kids. But, and the last part is a parent, I'm thinking whoever they go home to, is there an accountability piece that the guardian or the parent or wherever they're going gets them the targeted case management and into the services so they don't go back into the system?
So the answer to number 1, as far as the numbers, I'll have to get that for you. I don't have off the top of my head the number of children that are at risk right now. Number 2 was, repeat number 2, I'm sorry.
The assessment y'all are doing when they're incarcerated.
Yes.
Does that conclude identification like PACE does? I read one of theirs last night, and it is incredibly comprehensive. They do a psychological, a trauma assessment. They identify, and then they're sending referrals over if they think they have DD, IDD, autism. That way they can possibly tap into any type of services.
So that's what it's designed to do. So we're going to do all of the evaluation and diagnostic and assessments that are available to us under the EPSDT while they're in that 30 days prior to release. And then we will send all of that assessment information to the post-release provider to make sure that the treatment is then followed through with. And then for number 3, there is an accountability piece with regard to the targeted case management providers following up with parent guardian to make sure that these appointments are taking place.
So, I was just going to add a little bit to that. So most of these kids are coming out of a DYS facility, so there'll be there are juvenile detention facilities across the state that DYS does not run. Some of those are run with a lot of assessments going on. So the one in, Washington County is just amazing. They have a whole team of social workers that work there. They call us all the time about, oh, this kid got psychological testing. We think that they need waiver. They're really good. Some of our other juvenile detention facilities don't have those kinds of resources, so we may not get as much either notice from them. But in our DYS, they come into a program and they get a very thorough assessment on the front end, very thorough, and it is wonderful. And we have had that relationship with DYS in the passes. So almost all of those youth, we've got a couple of master's level clinicians that work at DYS. So almost all of those youth already have a system where they're coming right out into the pass. So this will be an added piece to it, but mostly they might be updating some of those, but a lot of it is screenings, not full blown. Like you're not going to see a full blown psychological assessment with an IQ score. That may have happened on the front end, particularly, with the DYS kids. And so what we were already seeing is a lot of those kids basically coming out and going directly into the passes with all of that. And then they're coming in the front door of the behavioral health. And then we're really very much relying on the passes to do some of that back end work. But again, those two providers, our DYS provider and our Washington County, will do that digging in, right? All kinds of school records, all kinds of stuff. So you're going to see, we've already been doing that, but this just gives us an ability to maybe pick up some more kids. So I think, if I'm guessing, probably 80% of them are going to come out into pass. Maybe you think it's going to be even higher? Yeah. So. Okay. So I think then you're not going to see that ongoing, that care coordination is going to be immediately picked up by the pass. That's right. And so what we see a lot is if you're not able to get them on the waiver and they're carrying a mental health diagnosis, right, you don't have that ability. Now, again, if you do it on the front end, obviously 30 days is not quick enough. So if they're carrying a behavioral health diagnosis as well, a lot of times we'll just put them in through that BH door, and then the passes and the families do that work on getting them identified as waiver eligible.
On that door, a lot of times the care coordinators are not going ahead and getting them into CPS waiver.
Yeah.
Like you can access the survey until you're in it, but then they don't know how to get it.
So, yeah, and I think, we built a lot of services in on the BH side, because really the additional services that we're talking about for IDD are mostly supportive living kinds of, right? And so, yeah, and so, there is some small ability to do some supportive living, but, absolutely, if there's some knowledge of, that they're duly diagnosed, I mean, that's the piece is of really making sure.
I think when I worked with Empower, we talked about this type of program, and the beauty of the way you built the passes is they could go in because care coordination is not available service prior to the family coming out and doing a full transition plan out. And then they're helping them get those services. I don't know if that's the way you guys are wanting to do it now, but it's kind of like in Colorado, when I adopted my son, his adoptive worker, we went in and we had a whole transition plan into therapy and into the home. But if they could go in, we talked about this with the adult population too, for reintegrating from the prison system. So I don't know where you guys went with that, but I know the white paper that I helped write, that was trying to get us inside there before as a warm handoff so the family knows and the kid knows. And I don't know if that's what is happening now.
So we can only do that. We can only get them into a pass if they have that behavioral health diagnosis and they have a serious emotional disturbance. So that's what we can do. Otherwise, we can't. We don't have. We're not able to identify people who need help filling out waiver applications. And yeah. So,
And I'm saying, can you get them assigned to a pass before they come out?
Oh, no, we cannot. No. And so you have to open up in a limited Medicaid eligibility category because we cannot make that pass. As soon as and we've had that challenge, you're exactly right. So before this, we couldn't, we couldn't turn Medicaid on until the day they walked out the door. Mm-hmm. And so because it's such a limited service array that you can provide, we can't, if we turn on pass, or if we turn on regular Medicaid, then pass turns on, and we've made an unallowable payment to the pass, a cap payment. So.
But we will be able to do better coordination.
That's right. Mm-hmm.
And I was just going to piggyback on what Paula said. She covered most of what I was going to say. But one of the things in the CAA, and Reagan, you can correct me if I'm wrong on this, but it allows us to use those assessments that Paula was talking about for the EPSDT assessment. So they can go to the targeted case manager, they get all of that information, and they can use those comprehensive assessments that are done on the front end to be part of that comprehensive plan to create a transition plan for when they leave. No, they're a provider that enrolls with Medicaid. Yeah. So right now we're targeting existing community-based provider organizations like Rites of Passage. They're already working with this population. That's not a limit to say that if you meet the qualifications, you can't come and be a provider. Mm-hmm. We want that, but we needed a place to start, and this was a good place to start for recruiting providers with this population. How many providers do y'all have? Reagan?
Oh my gosh. We've got right now, there's 3 that are actively providing the service, and we're looking at about 14 total in this space. Now that means that they've got to go through the provider enrollment process and actually get enrolled.
Which we do in like 2 weeks now on average, so.
And you think about the population, and this is a very short term, particularly if most of them are going to pass, like they're only going to be providing 30 days of service, right? So it really needs to be an existing provider. I can't imagine that anybody would start this up as a Medicaid business. It's almost like you would need to layer it on top since it's such a small amount of children and then a short amount of time that you'd be providing the service.
And a lot of these services are already being provided in the spaces. As you said, they come in the door, they're already getting their assessments. It's just that Medicaid does not have visibility into that. And this will change the reimbursement mechanism for those services.
Just think about that transition as a whole, and it'd be great whatever services they are getting in that 30-day window, the transition plan, kind of like a transition of care authorization, passes over to the passes to honor. Okay.
Mm-hmm.
maybe this will be a model for the adults that we were trying to do a
Yeah,
couple
I
years
think
ago.
so. And we're already doing. I don't know if we've talked about this, but there's a community reintegration program that opened up in targeting DYS releases, and so we've been doing that a lot. Right now, they're not. They haven't been. CMS has to clear them as a home and community-based provider, but we've been able to. Working with the passes on. Our goal is them coming right out of DYS, moving right into community reintegration. So this, right, talking about honoring an authorization, right? So they're going to hit the pass before they've been authorized for that service. But then having an entity like this saying, yes, they need this service, then it really puts a lot of pressure on the passes to say, yeah, I'm going to authorize that. And we may even call it like a PCSP. Yeah, yes, exactly. Yeah.
Any other questions, comments?
Service it's added on. What type of provider do you see is applying to be?
It's carceral providers that are already providing the service in these environments, who also have the ability to then provide services as a home and community-based service as well.
Okay, so like social work type.
So group. There's a group called WellPath who does it in the prisons. There's a group called Turnkey that does it in jails. So they've done it, and then some of the DYS providers, they have like aftercare contracts with DYS, and so I think those are the big ones that we see.
There's medical, and then there's the CBOs that are doing more of the
case management
piece. So there's like the WellPaths and Turnkeys are doing a lot of the screening and medical, and then the CBOs like Rites of Passage are doing a lot of the care coordination already. So we're kind of targeting those. And really the carceral providers are the ones that have the ability to get into that facility. They have contracts with those facilities. So they're the easiest to target for providing those screening services.
Or are you talking about like the education level of the people providing the service?
You get called in sometimes as we're OTPT speech, but we also are serving some adults now. But we also help with connecting to waiver providers and some different things. But we have a social worker that works with us. But we get called into some pretty difficult situations where sometimes they're in juvenile or they're in some other program that would be similar, but trying to get them moved out. So we kind of work in this area a little bit, but not completely. But.
What is the direct provider, the case manager criteria?
LCSW, LM, licensed psychiatric nurse, along those lines of professional.
I just wanted to give a plug to the DYS program. I see them, they talk about the thorough assessments that they do, and then they're talking constantly about the ongoing training, and I've actually got to be there and engage with them. They're eager. They have MSWs, LCSWs, lots of folks who are there who really want to learn and try to help get kids to a point where they have a toolbox and skills so that when they're discharged to all these wonderful services, they're ready. So just want to give a plug for them.
Thank you. Take that back to DYS. I'm sure they'll love to hear it.
It's been really fun to work with them. We don't get to a lot at DMS. I think Paula does more, but we're kind of siloed, not getting to work with them, and it's been really fun to learn more about what they do.
At all? Thank you. I appreciate your time and attention.
And I would like to introduce you guys to the newly elected vice chair of the MCVC, Amanda Clark, and this year's chair, Jennifer Yeager. She was last year's vice chair. And Jennifer's going to go over the proposals that the MCVC had.
So, in our meeting earlier, we had a little bit of a discussion over the passes, and that's one of the things that we were really trying to get involved in, is how we can educate people on the passes and what they're offering, because we feel that the community does not know going into a pass. They have no idea which pass is going to benefit them the most as far as their provider and the services that they're getting. So we had asked, in the previous meeting, if maybe there was a way that we could have a quick link that would provide those services, or if there was something maybe that we could do education-wise for a client once they are assigned a pass. So that's kind of a broad thing, but that's one of our biggest, I think every member was wanting that to happen, because, when somebody tells you, you have been approved for pass, and this is the pass provider you're given, and you have 30 days to pick somebody, they don't know where to go. Like, they have no idea what websites to go to. They have no idea what they need to be looking for, what questions they need to ask, and where that person would be. Maybe if we could have an advocate, what would that look like? So that's something that we're really wanting to get a solution for. And then the other one, we had talked about assisted technology assessments, and we were just kind of wanting to know what the latest is on that. It was supposed to maybe be happening in 2026. So we kind of wanted to know where we were on that. And then the other one was the services for families that are on the waiver wait list. What services are going to be provided for those people who are waiting? Because we had asked about when you're on the wait, like on the CS, yes. Yeah, if they're on the waiver, is there any services that their family can receive while they're waiting? So that was our three big ones.
Okay, with that, I offer it up for open discussion, questions, what you guys would want to go over next meeting. Maybe answer some unanswered questions.
Just a couple things. I wondered if we could potentially get our presentations in advance. Sometimes it's a little hard to make sure we have thoughtful questions ready when we don't get this until the day of. Is that possible?
If it is available in advance, absolutely.
And one other, and I do have some questions. I do have a meeting with Elizabeth Monday, so hopefully I can get some of those taken care of next week. But I just hear so many people right now talking about the 27 session already, and I know there are still some, and this is probably looking this way, but there are still some rules that are outstanding. I know from last session. Do y'all have time? I know those aren't all in your control either, but I didn't know if you had any updates on any of those, particularly around like maternal and child health related rules. Okay. Okay, cool. Okay. Great. Great. I'm not going to ask you about dental health, don't worry.
Thank you. If you would like to learn about it, there's lovely recordings.
I saw them, yeah.
So response to the Jennifer, that was you talking about the wait list, what's the services available, the pass. Because right now it was the only care source, right, that was provided, but then now it's very, very restricted or, limited to only medical, maybe more high needs. And at this moment, probably there's none other. I don't know, anything else. The educational opportunities for learning about past, so like earlier, does this probably the link is going to be helpful to compare, that each pass, because sometimes it's like, what providers can say, there's we had a limited what we can say, what cannot say. And then sometimes it's so different. It's like there's so many cases and scenarios to determine what's the definition of good. It might be good for me, but it might not be that good for you. Depends on the situation. It's so case by case. So hopefully it will help. That's the goal.
Yukiko, you always have the past panel at DDPA. I'm just thinking, well, Paula had a good suggestion about doing like a guide out. We're not just talking about the passes, but like choosing a waiver provider, just some tips. We know y'all can't tell us what to do as parents, and nobody can guide and influence because everybody would get in trouble and we'd be on the news. We understand that. We don't want anybody to be on the news. But I think those panels you do at the provider, but then again, it's just providers, but maybe just a thought, if we could bring some questions to get those answered from a member perspective from the Client Voice Council. I know I'm there and I asked 5,000 questions, but that was kind of open floor for the passes to answer any questions from providers. There's really not a venue like that. We had passes here one time, or even the waiver people that do the waiver stuff, just to kind of openly ask. I mean, as parents, we just don't really have that. We have the Facebook stuff, but so that's kind of what we're talking about. And I think a navigation guide, if you will, was what Paula suggested earlier. Kind of what'd you call it, Paula? A tree, decision tree, a decision map, decision tree.
Yeah, we had talked about just as you're new so we were going to put out exactly what they all cover, right? Just the baseline rules of it. So, just that thing of you can't, they have to provide, or they have to cover these services. So they all have to cover these services. This is their network, right? They meet network adequacy. And then where as a parent you would start clicking around on their websites of what you would want to look at. So things like that the Voice Council mentioned was do I already have a primary care physician, or do I have already chosen a provider, and so would I go there first? What section of the PASS website would I look at, right? So maybe just all those things, remember this or think of this, or this is what I would use to compare, So I don't know decision tree, or
we get the same question as a waiver
parent
provider.
guide, or
we get the same question of, well, what do you do differently that the other waiver providers don't? And we do have some different programs where I work, but I think that decision map would fulfill that. It's and if you, say, if you have a child that, someone told me today, they had 3 children with CP, where do you go? I mean, if you just don't even know where to start, well, I have high medical needs for my kids, so I need to go here, but my kid has autism or high behavioral, or I think that's kind of would fulfill it.
Anyone else? Is there?
Maybe Jennifer and I can talk after this, but to you. I wonder if it is that you guys can communicate with the all pass to set up some, not town hall, but some kind of thing. Right. Oh, that's right. Never mind.
I like that though.
They're not even allowed to present themselves in public. That's what
I'm just saying it's real tricky. And so if you had a room full of PASS members, right? And you had all of the passes and your CareSource, your Empower, your Summit, and your ATC, and I work for CareSource, and you're asking me questions, and then I'm talking to you, I'm prohibited from influencing her and talking to her that could be influencing her to come join my PASS. And so that's why that gets real tricky.
during open enrollment, because that would be the only time you would have.
Didn't the passes come to Medicaid Client Voice Council one time, and we did kind of a question session?
Yeah, I mean, they can come to Medicaid Client Voice Council. I think you're referring more to big rooms.
Yeah, like a town with just parents and members, because that could be very, very tricky.
But we need a go-between. That's what I'm saying. Like we need a go-between person that is not affiliated with PASS or Medicaid that can advocate for patients and say, these are the 4 options you have, and lay it out on the table. Because I mean, it's just asking somebody that's uneducated to go online and look at a PASS thing, and they're like, I didn't see anything they offered that my child needs. Like that's what I hear all the time. Well, none of the passes offer ABA at this therapy facility. I have to drive 85 miles.
Yeah.
Like that's
and
not,
I mean, like insurance, PASS, their managed care, their insurance company, like insurance is hard to maneuver, right? And so, I think that, we have the ombudsman team, which they're really good about helping answer. They can't steer you in a place, but they're a resource to be helpful. We are doing website updates, not just Act 962. The PASS team, we've been working on a website update for OSAM that is like member centered, and then there's like provider, but it's an open website. And so like if you as a parent and your kid's coming into the PASS, because you get 90 days to make a PASS change when you are a new enrollee, and then you could look at the provider information that the state is sharing. You could go look at the PASS information. So like there'll be different tabs. And so we absolutely hear you. Like, I know it's overwhelming. I think to myself, I don't have children that are in the PASS that don't have, these special needs. And I'm just maneuvering regular insurance, and it's difficult, right? Absolutely. And so like we are working on small things like that. I just don't know that there's always going to be a solution that solves for all of these things, because every family is so unique, right?
Yeah. And I was just thinking, so maybe back to also, you don't go into on the behavioral health side, you're going to go in real quickly, right? But on the waiver side, you've been working with someone outside the PASS, because you're not going to go into the PASS until after you get approved for waiver. So there may be something we can embed in that process where you're working on getting approved for waiver, where for that group to say, okay, now that you've been approved for waiver, you're going to get assigned a PASS. You have 90 days to choose one. Since you're are coming in for your qualifying condition, here are some of the services that you might want to look for that relate to your qualifying condition. And that may be a place where they can also, with those during that waiver enrollment period. Does that?
Yes.
I'm looking at Kika because she's been in that waiver world for so long. Do you think that might be a place? Because, for brand new parents that we could embed a little bit in kind of talking through, because then they're not guiding the parent to a different path, but they're at least guiding them on, here's your, what you want to look for, what service.
Doors are very different.
Mm-hmm.
If you're coming in the PASS, it's the waiver door or the behavioral health door, right? And they're 2 different doors, and you'd be looking at 2 different things.
So we do a lot of, and I think that the 2 divisions, the 2 DHS divisions, do a lot of work on that, right? Because parents call us a lot on the mental health side of like, okay, where's the residential facilities, So we have to talk through that a lot about what to expect. So it may be in the divisions. That might work. Okay, good. Think about that.
That would be helpful.
Okay.
I think that would be very helpful for any of them going into that. Because even myself, I know all of them because I've been in the medical field and I work waiver. But even not just passes, but even I work for Easter Seals and I work for Myers Davis, and so even just those companies, we're not just hitting passes only. There needs to be education for all of these things. And I don't know how to do that. And not just trying to persuade people.
Yeah. Question on that. So we've been doing at Arkansas AAP, we've been doing some work around focus groups for moms and people of childbearing age on access to coverage and benefits in Arkansas. And this is through a subcontract from the Arkansas Insurance Department. We are trying to talk about learn about what women know about their coverage and access to benefits. And one of the things that we are asking questions about is who they trust and how they can navigate all this. And we have done some deep work on really talking about where Arkansas's brokers our certified application counselors and our navigators are, that are three different kinds of entities that can help people enroll in marketplace coverage and theoretically some Medicaid programs. And what I wonder is if there is a way, I don't know what the managed care rules are for the passes, but are there ways, can brokers help people enroll? Are there brokers or certified application counselor or anybody else who has that knowledge kind of the whole landscape who can help families enroll?
So with the pass, we serve the two populations, and so it is the provider. So on the mental health side, it's the provider of service that helps people navigate their way into the pass, right? So we don't even let somebody have. The only people that can make a referral for an independent assessment are a provider of a service on the mental health side. So you have to be getting counseling services. They've had to have given you a diagnosis, or a primary care physician that's providing behavioral health services. And so then they make that referral. And then on the DD side, it is, you go through DDS to get that waiver application, right? So somebody's going to have to alert you that you need that. So generally that's coming through schools or, some other source. These ladies here
I think Anna, that perfectly shows the example of what we're talking about for education. You're one of the biggest associations and providers, and you're asking how to get into a pass. Yes, I am. I mean, we have people that call us and say, how do I get into a pass? And some people just don't know. I mean, it's just, well, we're not talking. Well,
how do I get out of pass? I don't like it. Generally, a lot of people. That's not an option. Sorry, I think eligibility is a big question.
And I was just going to answer from I'm not talking about from what I learned from you guys was that the Ambetter Medicaid, that's different than like a broker signing you up for like Marketplace, right? Or can we talk about the difference in that? Maybe I forgot about that.
So our home is the same. The plans we purchase on our home are the same plans you can purchase on the exchange. So your Ambetter plan is basically the same. Services they offer are basically the same. The copays are a little bit different, so they, may name it the Our Home plan because you pay different copays than everybody else, but you're getting the same silver plan that's offered on the exchange. So a navigator can help under the Affordable Care Act and our state-based exchange, help a member find a plan. And I actually think AFMC serves as a navigator, so they can probably tell you more about that role that they're doing. The restriction is Medicaid cannot pay for navigators. So we as a program cannot pay for that service. That is, we're not paying AFMC to do that. So does that help?
If AFMC happened to have some information
Don't
about
get me
that.
to talking about that. I have no idea. Medicaid is prohibited by statute from paying for navigators on the exchange. Yeah. But I believe that under AID, there are some navigators on the exchange. I think it's through AID.
I know this because we made one flyer that has pregnancy Medicaid, Our Home, and Marketplace coverage on one flyer.
You did. It's nice. It's a nice flyer.
It's gotten a slight tweak lately. But we put that on there along, and we have one that is in draft form that has all the information about navigators, certified application counselors, and brokers and agents who are all able to help people enroll in various.
Yes. And there are brokers that work for the separate insurance companies that can help you enroll.
Some are unaffiliated too, so can
right.
all of them, it seems, at least to my understanding.
None of them, however, are paid for by Medicaid because we are prohibited by statute.
Correct.
To do that. So,
yes.
Anything else?
Are we talking about next meeting yet? Okay. I wonder, Elizabeth, I know we've had a couple conversations about school health, and I don't know when that will be ready for a conversation, but when it is ready for a conversation, I'd love to maybe bring that here because I think there are a lot of folks who care about what is happening.
So there's a couple of different things we're doing. One I think we'll be ready for sooner. We're targeting August for the start of the school year. That is subject to all of the same timelines and approvals that everything else is. But that is for Medicaid to cover school nurses that are providing services, health services under a health plan signed off on by a PCP. If it's signed off on and you're doing that, then Medicaid would would cover it, just like other school services. And then as part of that, we're also looking at how to include more transportation to schools. So I think is it New Mexico or Arizona? I don't remember the state that we're modeling it after, but basically they're able to pay for transportation to the school for children who have an IEP and are receiving an IEP service that day. So if you're putting a kid on a school bus and providing transportation to a Medicaid school service, Medicaid can actually, that's not emergency transportation.
Is it possible
This
to
is getting them
transfer
to
to
school. So that's a different issue. I'm talking about like the school transportation.
Yes.
So if you're
Okay.
if you want to
They
talk
have to
about
come home, in
getting
other words.
a non-emergency transportation provider to a school to get them to take them to therapy, talk to Reagan.
Okay. Yeah.
She's our non-emergency transportation provider director. She's blessed. Blessed with that program. It's her favorite. So she can help you with that. That's a different issue. What I'm talking about is actually helping schools defray costs through Medicaid match dollars by helping them provide Medicaid services to their students.
Yeah, because a lot of families that have high needs children, sometimes it's the school nurse that is the answer to the question as to whether their child's going to be in school. Because if they don't feel comfortable that their child's taken care of, they're going to homeschool them. And
Right.
so it's a super, super important thing. I know especially juvenile diabetes also, not just developmental disabilities.
Yes, and this will cover those types of disorders as well. So they can do the medication administration, the testing, the glucose testing, all of that good stuff. So
Yeah. I assist families with applying for waiver. We have a clinic that has, we have about 2,000 patients at any one time for OTPT speech, ABA. But with the waiver, I've been kind of going through the individuals that need to apply. And what I'm finding, it's a lot of homeschooling families. And so it does seem that the school systems, I do occasionally, like especially our smaller districts, I'm assisting with, but for the most part, it's a lot of the homeschooling families. So it was encouraging for me to kind of figure that out once we started really looking into it. But the schools are doing a pretty good job of getting them on the CS waiver if they need it, apparently.
Oh, good.
Yeah.
That's good. So hopefully we can come talk to you closer to the start date of that. We're working with ADE. Then there's a bigger project that we're doing cross-divisionally. So OCM, I'm looking at Paula, she may be surprised right now, I don't know. DDS and DMS, we're not including aging in it, but you know. We're trying to look across all of the divisions and Medicaid at school comprehensively and just trying to make sure we're doing everything we can to maximize what Medicaid can do to support children in schools. So. Sure, can they get the assistive technology?
Does anybody have an update on the?
DDS left, but we will put that for next meeting.
Yes.
Okay.
I know personally, I spoke with Mr. Ray from Simply Home last week because we're doing some stuff. We want to go ahead and be ahead of it as a provider to put that in our comprehensive assessments.
Okay.
But
yeah,
I know you were also asking to see where we're at.
Yeah, we can ask Dee Dee to do an update on that, and if they're ready for next meeting. Okay.
Anything else someone may want to?
Okay. Are we in 240? Oh, that's on the timeline. I said, okay. Yes, I am. Oh, but I have like 4. Does anybody else has more? Can I go ahead and start my 4? Okay. Yeah, I know Jennifer left, so maybe this is just for the record. But we need to, representing like a DD world, we need to get the status or some kind of timeline for the CS waiver rate review. What's gonna happen? Is anything gonna happen? I know. Yes, and I ask these 4 questions to Jennifer and Melissa, like I think every 3 weeks. I send them an email. They probably know what those for. But for the record, number 2 is the ADDT EIDT rate review report. We submitted our information back in July. Melissa says still under the review, but it's like, are we gonna know the result? We're not expecting, but want to know the result. Third is the ICF, 16 beds above and below rate reimbursement system. I know I asked this question, Jennifer and then Melissa. The last one is the independent assessment. I know the DD was not included or excluded. We thought it's like, okay, well, if we can simplify it for DD, because, unfortunately, our folks, they won't get better, right? The IQ won't get, things won't get better. There's less changes. So if it is like, less frequency or simplify. Yeah. But I think DD was excluded. DD.
No, they are also going to do the abbreviated reassessment.
DD too?
DD as well. Yeah.
Okay.
So yeah, we have started that with BH. We have to have some federal approval, some CMS approval for our abbreviated reassessment. They do not, and so I think it's going to be as simple. I hesitate to say simple anytime I'm talking about any Medicaid anything. But I think we are not going to have to get federal approval. So I think it's just working directly with Optum on the what do we call it? Abbreviated reassessment. We had to be really careful what we called it, but abbreviated reassessment, and then putting anything in state rule. So I think they're just going to align with us if we have to open up a manual. And yeah, abbreviated reassessment is on for them as well.
All right. Thank you so much.
If there was a status change or something, I guess there would be an option for them to do a full reassessment.
Absolutely. I'm glad you brought that up. I forgot about that. Optum came back to us and suggested, that sometimes people really feel like they need to talk about their full experience. And so each person at the time of reassessment would be given that option to say, we can offer you a shorter reassessment, but if you feel like things have changed and you need the full reassessment, then they would be. So it will be members' choice. Mm-hmm.
I'm going to blame you, Kiko, on my question, but it brought up some other markets and states with Optum. I used to work for Optum, and some of the people I used to work with are saying they're doing for lack of a better word, a complex care, almost like a DD-IDD type of assessment. Like I know in the passes right now you have a complex care category, but it's limited to certain members. Is there any plans with Optum to account for a comprehensive assessment for like our members? That I know what you're saying with the reassessment, but in order to get them in it's not about the money, but a higher rate category, because right now the highest category you can be is tier 3, right? DD-IDD. But there's very few tier 4 slots, which is the highest rate, but that's technically high medical, like what we would see for a 24/7 person.
Yeah. So
you know what I'm talking about?
I know exactly what you're talking about, Amy. And so I think the piece of that is when we started out on the DD side, there were 2 tiers, tier 2 and tier 3. And so tier 2 was a DD member that did not have extensive needs, and tier 3 would be more extensive needs. The way this is filtered out, when we projected it, we thought there would be 80% of the people would be in tier 2 and 20% of the people would be in tier 3. It flip-flopped, and now it's almost everybody who comes in is in tier 3. And so there's a broad range of needs for just one capitated rate. And so I think, we have not approached that yet of medical complexity. Do we need to do something for medical complexity? Because you're right. What we ended up doing, we started and we said duly diagnosed, that's what we were looking for is that we would start duly diagnosed being behavioral health and IDD. Because really it was not as much about the money, but it's about those individuals, there's such challenges to find service providers and the services that they need. And now we've shifted in that complex care tier, that tier 4 has been more targeted towards the individuals who are multi-system involved, which means they're involved with juvenile justice or child welfare or the justice system. So really targeted more to people coming out of our state hospital, those people. And so I think we're getting a lot of requests, from the passes and from everyone to say, what do we need to do about a medically complex kind of issue, and how would we approach that? So we have not discussed that internally. We've needed to make sure that we've, operationalized every single thing that we got passed during the session, to make sure that we have all of those things implemented. So I think once we get all these things settled, we'll be going back internally to talk about a medically complex tier. But I want to make sure that I'm hearing.
Yeah, that's exactly what I'm talking about, especially given we went to DDPA and some of the passes are requiring the providers to go to a hour by hour if it's a person that you take care of overnight of what you're doing to justify your services. Because in that manner, the passes to me are functioning like traditional managed care, review medical necessity. I just want us to be ahead of the game from there. If we had something with Optum for that medically complex, that would help us as the providers to justify that need for like the kid that needs to be suctioned out at 2 a.m. to live, that I'm watching for seizures at 3 a.m., because right now there's really nothing, for that. It's because it's the other definition of complex care. So you're absolutely, that's what I was talking about, medically complex. Thank you.
Yeah.
Anyone else?
I have one more just for Paula. Sorry, all the pop quizzes. Was thinking about you last week when we had the 24-hour SAMHSA is ending everything and then not situation. Do you all have any direct grants from SAMHSA that would have been affected by that change?
Yes, we met with providers that day and said, your services ended. We can no longer pay you as of yesterday because we got notice.
Like Specialized Women's Services and some others, right? But
so it was 2 grants. It was actually our behavioral health integration grant that's sub through UMS. Yeah. It was that one, and it was a prevention grant that we had.
Oh, so not the Specialized Women's Services piece? I thought for some reason that was
it was a Partnership for Success. It was a prevention one. So those are the 2 that got hit, and so we gave notice, and then
everything was fine.
Yeah, and then the next day we came back to work, and they said never mind, and we said okay. So then we had to said everybody please restart your work.
Cool. I just wanted to make sure, just as we're thinking about, I know many of us are kind of thinking about the federal environment being uncertain and what that looks like at the state level, and just thinking about how services are part of what's happening here in the state. And I just wondered what was impacted.
No, it was, and I was tracking because I was getting emails from other providers around the state or other grantees, and I was trying to kind of make some associations because the way the announcement came out, it said something like, SAMHSA has examined all of their grants and something about their focus and what they found important and what they were going to focus on. So I was like, well, what did they find not important? Like, where did we get hit kind of across the board? And it looked like mental health first aid got hit across the board. Prevention, substance abuse prevention grants got hit across the board. I think some of the rural health, I saw that rural health group got grants that had some peer stuff in them. But those were the associations I saw because I was like, okay, where are you guys driving? Just like you. I was like, okay, if that's what you're prioritizing, then let's make sure that obviously we had, and those are our only, in Arkansas DHS, those were our only 2 true discretionary grants.
That question brought me back to one last question. What's the future of the SSBG? That is it. The future is gonna come back.
What is that?
Social Services Block Grant. So it's been, we've had some difficulty with our awards. Jay has SSBG as well. We don't know. Okay. I mean, I don't know if you have anything to add, but I mean, it's basically we.
Right now, I think we have funding through, I think it's January, ballpark. Yeah. Let us follow up with you on that. The state may get award. It may be a partial award, but I don't think we're really sure yet what that funding level is going to look like. So I hate to make a commitment to say we're going to either get it or we're going to even get any of it to push out to providers. It's been really sketchy. Even when we got an NOA on that, I don't think the funding necessarily followed immediately. So I have to get with finance to understand better what that may look like. And as far as the future of it, if you've got a magic 8 ball, we can all shake that and kind of understand what it's going to say about social service block grant, because it's just been, it's not been something we could count on this fiscal year. And I know that's difficult on providers, but we are in a position, I think, as an agency, we would rather be upfront and say, don't provide services using this funding stream if we're not sure that we can reimburse it.
Right, right, absolutely. Thank you.
Anyone else?
I just wanted to let y'all know we are having our 4th annual conference, April 16th. It is the Arkansas Behavioral Health Integration Conference. It focuses on team-based care, and we look at models of behavioral health integration. I think that integrated behavioral health really aligns with the mission. When I look at CMS and their mission and initiatives, and one of the things that I see a lot when I'm looking at the MAHA website and those kinds of things is they're looking at innovative primary care pilots and value-based programs. And so all of this aligns with our mission. And so we would love you all to mark your calendars, and we'll be sending out more announcements. Yes.
Thank you. Anyone else? All right. With that, we adjourn. Be safe going home.